Welcome, everybody. Rush University Medical Center, Division of Nephrology Renal Biopsy Conference for April 27th, 2023. Today's CME activity code is 488391. We have nothing to disclose as usual, and patient confidentiality has been preserved by changing all identifying information, etc. Today we've got a fun case. We're going to break it up a little differently. We're going to do a poll halfway through the protocol, and we'll work through the rest of it as we go through. We have 3 polls today, so we're gonna have some fun. This is Dr. Whittier's case. Bill, you want to take over?
Sure. We've got a 30-year-old woman who has she's a young woman with past medical history of childhood anemia, who presents during her 3rd pregnancy with microscopic hematuria and proteinuria. Her prior pregnancies 5 years ago and 3 years ago were completely uneventful. She didn't have any abnormal urinalysis findings during those pregnancies. She has no symptoms and denies any gross hematuria, frothy urine, leg swelling, skin rash, joint pains, fevers, chills, cough, anything. She's completely asymptomatic. Her blood pressures have remained normal up until this point throughout pregnancy. She's on no medications and no herbal supplements. So like I said, she was first found to have protein in blood at 16 weeks during pregnancy, and her prior pregnancies were negative. And that's when she was found to have a UA, which had 2+ protein, large blood, and 25 red cells. It was repeated at 22 weeks and was similar. And that time she had some serology done and a urine PC, which was 1.9 grams per gram. So her serology showed that her MPO was mildly positive at 6.7. Her PR3 was mildly positive at 9. And her ANA was mildly positive at 1 to 160. Her complements were normal. Her double-stranded DNA was indeterminate. Her Smith was actually negative, and her urine culture was negative. So this was all around 22 weeks.
So we're going to start with a poll number 1. So everybody, what would you do? Would you choice A, biopsy now? Choice B, start steroids and biopsy shortly after delivery. 3rd choice, do nothing now, a biopsy shortly after delivery. Or the last choice is wait 3 months after delivery before deciding on a biopsy.
And we can go back to the case to refresh everyone's memory here.
Yeah, so healthy woman with childhood anemia, and 2 prior pregnancies were normal, found out proteinuria and hematuria at 16 weeks, and now at 22 has some positive serology. Normal renal function, and if that wasn't in there. The creatinine was 0.6. Blood pressure was normal as well.
Right. You can see the
Nobody
results.
can see your votes. We're not getting as good a response. People vote.
I'm gonna have to close it. Let's see. Hold on. Relaunch. No,
Don't make me come after you now.
I don't think any. They won't be able to add any more. So
Okay.
let's stop there.
Well, as usual, we've got a whole array of different answers. 40% said biopsy now. That's the winning vote. 20% said start steroids and biopsy shortly after delivery. 13% do nothing, biopsy shortly after delivery. And the last one is wait 3 months after delivery before deciding on biopsy. So Bill, Casey, what would you do? Tell me what you would do with this situation and why.
I would like to biopsy her now because the further along she is, the more difficult technically it would be to biopsy her. And if things kind of blow up and her creatinine starts to go up, I want to know what I'm dealing with in case I need to immunosuppress her, put her on steroids or something. I'd rather know now. Ideally, I would have biopsied her even earlier, but if the question is 22 versus like 32 weeks, I would do it now.
Would you treat her? It's a Friday. Would you treat
If I'm
her?
biopsying her, no, I wouldn't. I mean, creatinine is normal. I would wait for a biopsy. It takes 48 hours. That's, it's not I'm not dealing with an RPGN at least based on normal creatinine. So I would biopsy her, and then I'll see what it is, and then I'll treat her based on the histology.
Would you do it yourself? Would you send her to IR? Would you have her lie down? Would you have her sit up?
I send everything to IR.
Okay.
Are you kidding me? Pregnant woman, definitely IR.
Well, there was a day when that wasn't the case, and I
Yeah.
think we've all biopsied a
Those
pregnant
days
woman.
passed.
And the decision to whether sitting up or not obviously depends on their belly at the time.
They used to also look at the KUB and the light and then just go blindly. So
Yeah. So anybody feel differently? Anybody feel strongly about not biopsying now? It was the number one choice, but it wasn't hardly a mandate. Well, they either don't feel strongly or they don't want to speak up, which is both fair.
Well, I mean, at this point, it's you ideally, and I think Bill will probably go into this, is, you know, the risk, she's 22 weeks now, so she's in that range where, you know, in terms of bleeding and pregnancy, that it'd be, you know, you don't have much time left. You typically, I believe, want to do in the first trimester, otherwise you're going to have to wait. So I think that would be the argument of, hey, she's already 22 weeks. Are you going to wait and try to empirically treat whatever you think it is, or you're going to go ahead and quickly get it done and go from there?
Dr. Reen, what did you vote for?
I actually voted for biopsy, and my reasoning was that her previous pregnancies were uneventful, so this is something new. There is a serology which is concerning to me, so if it is before 25th week of pregnancy, I will go for biopsy actually.
Have you done a lot of biopsies in pregnancy?
One. Only one, and that was done by a radiologist, not me.
Yeah. All right. Why don't we get
Roger?
yes,
Roger?
Dick? Yeah.
Yeah, what's wrong with the minority view of just watching this patient? I mean, the patient's doing well. It's normal serum creatinine, normal blood pressure, no problems with previous pregnancies, only a gram, less than 2 grams of proteinuria, a little bit of hematuria. I agree the serology is concerning, but boy, I just don't think that this is terribly meaningful in the context of this patient. These all may be false positive results. I'm not overly enthusiastic about doing a biopsy. I would follow it, but
So you would actually you would follow. You would just hang in there a bit, huh?
yeah, I mean, I follow her very closely as a high-risk pregnancy, but I just don't get the notion that a biopsy is going to make a big difference in how this patient's managed. But
Well, I'm glad someone spoke up, because I think we look at these serologies and they're pretty, they're not high titers, but they're scary diseases. And if there's a time to biopsy her, I'd rather biopsy her now than in 6 weeks when creatinine's rising or something. And maybe that would be the tiebreaker for me. But I mean, it's certainly a legitimate point. And she's got 3 different, which is kind of interesting too. I know she's not taking anything. I mean, we didn't really go into it, but it's not on hydralazine or levamisole or anything like that. And those tend, with drug-induced vasculitis, tends to be much higher titers. But anytime we see kind of this mixed picture of ANA, PR3, MPO, I always worry about some exposure. Bill made the point of no medications or herbal supplements. So we've got really some pretty strong opinions either way. Bill, why don't you give us more of the case?
Yeah, that sounds good. So actually what really happened is that the proteinuria was there and she wasn't referred to nephrology until 32 weeks. But we kind of wanted to see what people would do at a 22 week if that was your patient. And so at the time of 32 weeks, because she was told by OB that she had gestational proteinuria, and then sent to nephrology. Nephrology saw her at 32 weeks, and that's when the MPO and PR3 was positive, and everything else was about the same. So she still had an active urine. She still had over a gram of proteinuria. Her serum creatinine still was 0.6. And everything was basically the same as it was at 22 weeks. So OB knew better, I guess, to not need the biopsy because everything had been stable. So her past medical history was really nothing except for this childhood anemia. She'd not had any miscarriages. She delivered two healthy children, actually. That's a typo there. And she's got no medications, like we had said. Social history was essentially negative. She was of Palestinian descent. Her blood pressure was normal. And other than being 32 weeks gestation, there was nothing on physical exam. There was no edema, there was no rash. Her lab showed that she was actually not anemic, 13.8. Her white count was normal. Her platelets were 159. Her creatinine was 0.6 prior to delivery, and then she actually delivered a healthy baby, and 1 month later is when these labs came back. So she had gotten through pregnancy, she delivered, had a normal healthy baby, and 1 month later we repeated the labs, and her creatinine had gotten close to a pre-pregnancy value of 0.7. Her pre-pregnancy value was 0.8. Her albumin was normal. Her ANA and double-stranded DNA are there that we already mentioned. Her anti-Smith was negative. Her anti-LA was a little bit positive. Her anti-Rho was negative. Complements were normal, and the ANCA titers were as we said. Her GBM antibody was negative, and as was her infectious antibody. Her urinalysis still remained active, and her proteinuria had increased to 2.65 grams per gram. So this is about 4 weeks postpartum. And like I said, she had delivered a healthy baby at 38 weeks. Her blood pressure throughout the entire pregnancy was normal.
It's interesting that her proteinuria actually went up after she delivered. Usually it goes up during the pregnancy because of their volume expansion.
So we had like a one
afterwards.
Yeah, we had a 1.9, and then we had a 1.5 at 32 weeks, and then around 36 weeks it was 1.9 again, and then 1 month afterwards it was again, these are all PC ratios, but that was when it had gotten up to 2.6.
So we're going to run another poll now. So based on what you have now, what will the biopsy show? Will it be a lupus nephritis looking lesion? Remember, she has some lupus serology, IgA nephropathy, some heredity form of renal disease, basement membrane disease like Alport or thin basement membrane disease, endotheliosis, or an ANCA-associated GN?
Let's get a better response rate this time. Already better.
I guess they figure if Dr. Glassick can disagree with the majority, that they'll feel comfortable voting.
Icebreakers.
Exactly. Now they want to know what Dr. Glassick is voting.
Yeah.
Actually, he doesn't get to vote because he
doesn't get to vote.
host.
You can put it in the chat, Dr. Glassick. But okay, perfect. End poll.
All right, so we've got 21% buying for lupus. I mean, she had some anemia. It's a young woman. I mean, that's a reasonable. IgA nephropathy, certainly reasonable. Hereditary disease is fourth, and I guess it would be second. So in order, it's IgA, ANCA, lupus, and then a hereditary disease. Casey, what do you think it's going to show?
I really like that order. I think that's actually my my differential in that order. I think that I'm not really sure if this would be one of those hereditary lesions, because she's had documented UAs in the past, 2 other pregnancies. She's never had blood in her urine. If she had thin basement membrane or Alports, I think one of those UAs in the past would have picked it up. That bumps it down for me. Being a young woman, I like the idea of lupus. She doesn't have any other, the anemia from childhood, that's interesting. But, her double-stranded DNA complements, everything is normal. I understand that those can be normal in patients with systemic lupus. It does fit. You can't really rule it out. I think this is why I think that biopsy is needed here. In fact, lupus, IgA, and ANCA vasculitis are all on the differential here. Again, the fact that she doesn't really have hypertension, endotheliosis, I'm sort of not buying it. I feel like normal blood pressure in somebody with endotheliosis would be pretty unusual. So I'm going with the 3, IgA number 1, because of the amount of hematuria and proteinuria that she has. The creatinine is probably elevated in pregnancy, but it's not very much because her post-pregnancy creatinine was 0.7. But young people can hide necrotic lesions and crescents pretty well with a normal creatinine, whereas the biopsy will show an active lesion. So IgA, whether in its traditional form or non-necrotizing versus a necrotizing IgA, is possible. Vasculitis, I feel like she would have some symptom. Her blood pressure is really normal. So again, I'm not really, I can't really differentiate between those 3 based on her presentation. So I think a biopsy is probably needed, but I would rule out endotheliosis.
Well, I hope so.
Yeah, I would rule out endotheliosis and hereditary lesions, and I'll put the other 3 on top.
Yeah, I remember this all started at 16 or 18 weeks, and that would be extremely unusual for endothelial. And it's just not how it presents, but yeah. So your list is good. Dr. Rubin, what do you think this patient has?
I wholeheartedly agree with the differential that was described, and I think her husband is George Constanza. He will be asking, is it lupus? Is it lupus? And frankly, I think lupus is number 1. I mean, the association of positive ANA and ANCA has been describing lupus, and if it is lupus, probably will be a class 2. I don't think that the others are in the differential. That's all I have to say.
So for any in the audience that's not young enough to know one of the famous Seinfeld memes, it's George in his hypochondria thinking he has something wrong, and he keeps saying, "Is it lupus? Is it lupus?" So that's not something that's a great reference, but not everybody gets it. But you can always Google it; it's pretty funny. He says, "Is it lupus, meningitis, or scoliosis?" Which, of course, they all 3 have nothing in common, so it's pretty funny. Maybe we'll send you the link. Dr. Glassick.
Well, I'd have to go with the lupus story because of her age, the concurrence with pregnancy, the serology, the presence of hematuria. I can't obviously exclude IgA. That's always a possibility, but I think I'd lean in the direction of lupus.
I kind of like that for the reason that, pregnancy has a tendency to bring out lupus. I don't know that pregnancy has any tendency to bring, because Pravir or somebody in the chat said, why IgA now? Well, that's always the case with IgA. I don't think everybody's born with it. It shows up at some point, but at least if you're going to give a pregnancy association, something autoimmune kind of makes more sense to me. So I kind of like that. I kind of like that approach. Dr. Reen, are you in the lupus camp or the IgA? Are you team Rubin Glassick or are you team Gashti?
I'm team Rubin Glassick, but I also think if we think these serologies are iffy type, not that impressive, and she did not show any symptoms of lupus, at least I didn't hear anything. So I will consider a full house non-lupus with the MPGN pattern, which has recently been prescribed in pregnancy people. That will be one I will also think, but I'm on the lupus camp.
All right, so with that in mind, let's spin the wheel and see who reads the biopsy. You gonna put it up?
The wheel is ready.
You got the main screen?
Yep.
Oh, I don't see it. Okay. Hamoud.
All right, so here we can see a trichome stain, and we have 2 cores of the kidney biopsy. One is just partly showing, and the main one is here. I do see 6 to 8 glomeruli. Hard to tell if there may be some scarring within them, but we'll see in high power. Overall, the blue staining or the scarring. I just see some focal patches, maybe here, some here, some here, so maybe 5%, 10% of scarring. The tubules, for the most part, they seem to be back to back. So I think if there is any interstitial edema or any inflammation, we might see that up close, but don't see much right now.
Yeah, just minimal fibrosis. Overall, looks like a good core.
Yeah. Okay, so we are seeing the PAS stain. We have a glomeruli in the center. I see some scarring or mesangial mild expansion, or this might be some necrosis also, like only here. There are some cellular components here, so maybe it's some segmental active lesion over
Well,
here.
yeah, so you
here.
suggested 3 things. You got to decide on one.
Ooh, okay. I see some cells here, and this might be some necrosis going on.
No, so necrosis, is better appreciated on H&E,
Okay.
and it spills out into the urinary space. That's PAS positive mesangial matrix and expansion,
Okay.
and mesangial
Some
hypercellularity.
Okay. Some matrix and some hypercellularity here.
And the capillary
where's
loops around that area are open, so it's not a scar either. There's no adhesion in the Bowman's capsule.
Right, yeah.
And if you go over to 9 o'clock, the mesangium is expanded and hypercellular also. So I would say there's mesangial expansion and hypercellularity throughout.
David, for the trainees in the audience, could you please educate them why you're saying increase number of cells are present?
Yeah. Thank you, Ruben, for pointing that out. In a mesangial area, typically you should have up to 3 nuclei in a mesangial area. So anything more than that is hypercellular. So that area there, you could see, 8 or 10 mesangial nuclei. So that's hypercellular.
I actually thought Mario's point was this being a PAS, it's not that easy to see that it's, I mean, maybe it is for you. It's not always that easy for me to determine nuclei from just matrix. Now, where you said, yeah, I definitely see some nuclei, but a lot of times on a PAS, I'm not so sure how much is matrix or nuclei, or am I just not that good, David?
No. Yeah, you're right. Sometimes it is harder to tell. I notice sometimes the cellularity is lower on the PAS than the H&E, but in this case, it's pretty easy to make out there is hypercellularity in many mesangial areas.
The only other caveat that I'd like to add is, again, for trainees, is that you need to count the cells away from the hilum, never in the hilar area, because it's not that reproducible.
Yeah, that's right. In the periphery. Yeah, in the hilar, perihilar area is always, there's some hypercellularity.
And that's a good point. I think the hilum here is at 6 o'clock. But yeah, right there. But sometimes, that's a very unimpressive hilum, and I don't think I see afferent and efferent arteriole to kind of support that it's a hilum or a JGA. And sometimes, like what looks like the hilum there could actually be a tiny adhesion. So it's not the most obvious hilum, but David always puts the hilum at the bottom, and you can kind of see it bridging out like a tree there. So.
Oh. I don't know why I went forward.
Hamoud, it's very sensitive, so just give it a second. Yep.
Okay, I'm gonna go to next one now. Okay, so here we have an H&E stain. I see glomerulus in the middle with the obvious destruction / adhesion of the Bowman capsule and some scarring in this area. There's some inflammatory cells here and around the glom. On this side, I see some mesangial expansion.
Yeah, so you think that's a segmental scar then?
Yeah.
Final. That's your final answer?
Uh-oh.
You can dial a friend.
Yeah.
You could poll the audience.
Well,
Hamoud, look in the middle. Look in the middle of that lesion.
Oh, here.
Yeah, that and up a little bit. There's these little dots.
Oh, these one.
Yeah, yeah, what are those black dots?
Oh, is this the nuclear elements coming out? Is this some
We call that
necrosis?
nuclear dust or charactic debris.
Okay.
It's, nuclei that are breaking apart, and it's part of a necrotizing lesion.
Okay.
The arrow's on a little bit of fibrin right there.
Mhm.
And then there's early crescent formation. That's what the parietal epithelium is out at the periphery there. Yeah.
This one. Okay. So this pinkish material in between, this is not part of the scarring?
Well, some of that, no, some of that looks like probably mesangial matrix.
Okay.
And there's an influx of cells into the area also. No, but scars, we'll see one on a later slide, but scars shouldn't be this cellular. There's too many cells in this area, along with the necrosis and charactic debris.
Okay.
All right, so another glomerulus at high power.
Yeah, so here, again, some mesangial expansion everywhere, some hypercellularity, and these, I guess, some fibrinoid necrosis.
No, so those are unlicensed red cells
Oh, these
within the
are-
capillaries, but there is an early necrotizing lesion. Let's see if you could find it.
Is it this one?
No.
It's sort of a different color pink than the unlicensed cells. It's a little bit up closer to.
Go up and to the left a little bit. Up.
This
There you
one?
go.
There you go.
That's
Yeah,
it.
you can see it spilling out into the urinary space.
Oh,
That's a very early, probably as early as we could detect the early segmental necrotizing lesion.
Hamoud, this is where I play the color blindness card.
yeah,
I certainly don't see anything any different there. So
Yeah. So it's fibrin, whereas the other stuff is just unlicensed red cells.
okay. Yeah, these one I could make out they were red cells, but the other one I couldn't really. I thought that was some necrosis. Okay.
Yeah. So 2 out of 19 glomeruli had segmental necrosis.
Okay. Again, we have a PS stain. You can see like this obvious. There's a lot of necrotic material over here. Now, don't tell me this is scarring.
Yeah. So do you notice now that the cells are gone? There's no charactic debris or necrosis. So yeah, this is a segmental scar.
yeah, but David, it looks like glomerul the Bowman's capsule is completely blown up there. No.
Yeah, no doubt this was necrotizing in the past.
sorry.
Bowman's capsules disrupted, but again, this is scarred now.
Yeah, I just want to make the point. There's scars and there's scars. There's segmental scars that are just segmental scars. This is a big segmental scar from an old very bad lesion which destroyed Bowman's capsule. That's the point I want to make.
And is that just a very long longitudinal cut of the proximal tubular takeoff?
Yeah, it's beautiful.
That looks like an arteriole. It has endothelium.
Oh, that?
That?
Yeah.
Oh, I was with you, Bill.
Okay, well, thanks for correcting me. Thank you.
Yeah, because it has smooth muscle in the wall. Those are smooth muscle nuclei.
Oh, these one?
Yeah, that's it. Those are endothelium, and then if you go to the left a little bit, that's smooth muscle. Yeah, that's smooth muscle there.
Before we start getting into the immunofluorescence, I mean, what's still on the differential here, Hamoud?
So we still have okay, so we have some necrotic lesion. Lupus is still there. IgA crescentic lesion are still there. What was the other one? Vasculitis. Some necrotic lesion, so that's even still there. So
Roger, I'd have to point out if a biopsy was full of these lesions, specifically what we see on this screen, I couldn't say there's an active necrotizing glomerulonephritis. They're scarred over at this point.
Well, yeah, but I mean, if you don't have Bowman's capsule there, normal segmental scars don't blow out the capsule. That's
Oh, no, no, I meant no doubt this was necrotizing, but it's scarred over at this point. It's no longer active and destructive.
Okay.
yeah. We're just the problem is we try. You know, a scar is a scar, but not. This is not just a scar; is a scar. That's my only point. We've made the point. I'll drop it.
But this lesion would be called focal sclerosis if there are no active lesions, right?
Yep.
I mean, that's a secondary form of FSGS. It gets into this whole pattern of injury thing that we talk about it. Anyway, but yeah.
So I'm a little confused. So with this lesion versus if we were to do a PAS stain on this. Where did it go? This one. So
Yeah,
we would
that would not
see-
be completely scarred. That would still be cellular.
Yeah.
Yeah,
you
so we would see the same pinkish color as the other one, but we would see additional nuclei, right?
It wouldn't be as pink.
You just see kind of the
as
cells.
This one. Yeah, it's a bit more cellular.
Okay. Okay, so now we have silver stain, June. Mostly we still see these possible mesangial expansion or some necrotic, can't say from here. Then the thickness of the membrane seem okay. I don't see any holes or any spikes anywhere. Don't see any gap or any destruction. So overall,
What do you see here?
I just see some, like, again, possible expansion of this mesangium.
Right.
Or whether that's, yeah.
That's enough. I mean, we're not seeing what we saw before. We're not seeing the break. Unless I'm missing it. I don't see any breaks, crescent, etc.
Yeah, yeah. Nothing necrotizing in this gland.
Yeah. Okay, so we have the immunofluorescence positive for IgA, which seems to be in the mesangium area, if I'm not mistaken, mostly.
Yeah. Yeah, IgG was negative. There was no full house positivity.
Okay. So IgA is on top now. Okay, so we have EM. I guess this is the mesangium in the middle. We have capillaries on both sides. This is the urinary space. So we do see electron dense deposits, I think, in mesangium. This one, maybe some here.
Yeah, definitely that one you were on. Yeah, those are nuclei. The one you're on right now is a mesangial nucleus.
Oh, this one, okay.
Yeah, but where you were was it? Yeah,
this one.
keep going. There. Yeah, those are mesangial deposits.
Okay. Other than this, the membrane, I don't know if this is a deposit, but for the most part, membrane looks clean. And I don't think it's thickened. In terms of the photocytes, might be some diffuse, not diffuse, some focal effacement here.
Yeah.
Other than that, it looks fine. So yeah, so it's just mainly mesangial deposits, electron dense deposits here.
Yep.
Yeah.
And
Okay.
you remember, she's 4 to 5 weeks postpartum, but you know the endothelial cell doesn't also look swollen, or there's no evidence of endotheliosis here either. It wasn't really under differential after we saw the IF, but it's important to mention.
Right. Again, this is the urinary space. This is the capillary, and this. So again, there's some deposits in the mesangium here.
Yep.
Membrane, again, they look okay. I don't see any obvious deposits or anything in the membranes. Photocytes also look okay.
Yeah, they look preserved here in this image.
Yeah. So again, some mesangial electron dense deposits here as well.
Yep.
Again, so again, in the mesangial area, we have dense deposits.
Again, that's a cell with a nucleus,
this
but
one?
if you go directly north of that, you'll see a deposit.
This is?
Yep.
Okay. I'm always used to see circular nuclei. I don't know. But okay, so again, mesangial deposits, membranes look okay. Although I don't know if you would call these, I don't know if these are
Those are kind of organized. They're probably little organelles.
okay. All right. So membrane for the most part looks okay. Photocytes look okay for the most part. So again, we're seeing persistence of this mesangial electron dense deposits. Okay. So
Diagnosis.
yeah, so histologically speaking, IgA nephropathy with some segmental necrosis, some very mild interstitial mesangial expansion, and what 5 to 10% IFTA.
Good, nice read.
And there were 19 glomeruli on light. How many were on IF, David?
2.
Just 2. Okay. So 21 total, and 2 out of the 21 had segmental necrotizing lesions.
Yeah, we saw them both.
So is,
How many crescents were there?
Well, just that one had an early crescent formation that we saw, on the H&E.
Thank you.
so as Pravir pointed out in the chat, it was not lupus, and I think this is we've set a world record. I would dare to say that no other biopsy conference has quoted both Seinfeld and House in the same during the same conference. You have to know your pop culture, but they're both pretty funny. We're going to run a poll now on what people would do before we talk about it. So you have a lot of options here. We've got this lesion with, proteinuria, and but seems to be doing pretty well. I think the proteinuria was getting a little worse postpartum. So what are our options here? RAS inhibition and watch, just to basically just treat this patient conservatively. Number 2 is RAS inhibition and some systemic prednisone protocol, or RAS inhibition with either budesonide or sparsentan. These are 2 of the newer drugs that have been released for IgA nephropathy, or more aggressively, because of the nature of the lesion, RAS inhibition with prednisone, and I just put these all together because I didn't want 6 options, either MMF, cyclophosphamide, or rituximab. So you're basically saying some real form of immunosuppression that goes beyond prednisone, or the third here is, or the third here, some of the newer drugs that we're still kind of figuring out where they fit in. So please vote. Dr. Gashti's pointing out a monumental error on my part that says sarpanacin cannot be used with RAS inhibition, so choice 3 is no good. So if you pick choice 3, you can blame me because I'm not prescribed it, nor did I think about that when I wrote it. Casey, you could have done that in a private chat. You didn't have to call me out publicly.
The give or take a biopsy conference.
Yes, the good give or take of the good give and take. Few more
Good
votes coming
natured
in.
give and take.
Excuse me, Steve. Of course you know it. The good natured give and take. That was coined back when he was a fellow.
Howard Corwin.
Yes.
Just change option 3 to delete sparsentan.
I'm sorry.
Just change option 3 to delete sparsentan.
Yeah.
Make the comparison between systemic versus intestinal targeted steroids.
Yeah.
Then then there's a real difference.
Pretty
All
good votes.
Yeah, I think that's good. So number 1 is actually just watching the patient. Interesting. Number 2 is tied with 2 and 3. Hard to say what that means, but people want to do something, and only the smallest number really wants to get aggressive in spite of the lesion itself looking aggressive. But David did point out it was maybe 2 of a fair number of glomeruli had these kind of active lesions. You can look at the results there. Casey, what would you do? Would you watch this patient or would you treat her?
Is RAS plus SGL2 considered treating?
Yeah. So I should say conservative.
Yeah, I this is initial therapy. So I would do RAS inhibition, SGL2 inhibitor initially, and then if her proteinuria comes down, then I would do nothing. If she doesn't, despite that, then I would do a course of steroids.
And how long would you go?
With the initial treatment,
Yeah.
3 to 6 months.
Proteinuria has gone up despite her delivering. Can that sway you at all? When her GFRs fall and yet her proteinuria has gone up, can I sway you against being more aggressive based on
I
that?
think, I mean, her proteinuria is over 1 gram in both cases, so that puts her in that higher risk for progression category, but not necessarily. Like 1.5 to 2 grams difference on a ratio on a day-to-day basis doesn't really sway my therapeutic decision that much.
Mhm. Dr. Reen, what would you do above the border?
I first want to know, is she nursing her child? That's very important.
She is
what
nursing.
I do.
She
Huh?
is nursing.
She is nursing, so then the therapy changes. I know that RAS inhibition can be used in a lactating mother if you use an April type of thing. That's quite safe. So I wouldn't use any other April, if I remember correctly. So that will sway me, and I'm not sure about the safety of glucose transport inhibitors in this case.
Let me
So
interrupt you. Let me
Yeah.
interrupt you and say she's not nursing.
If she's not nursing, then I'll go with one.
With one, okay. So you're going to go with one either way.
No, I would not go one either way. I probably.
I'm sorry, yeah, because you're not sure it's safe
Yeah, if she is nursing, then my choice becomes actually steroids as a treatment of choice. But if she is not nursing, then I go with number one.
Oh, now that's really interesting. So would you advise her not to nurse then, to give her therapy?
No, I wouldn't. It's looking at her background, where she comes from, it was very difficult thing to discuss with her. But I know that there are certain. Sorry, I'm being paid also. There are certain RAS inhibition I can use in her case. I will suggest her that if she wants to go less aggressive therapy, safer therapy, which is RAS and glucose transport inhibitor, I'll have that discussion with her. But let's say if she doesn't, which my guess is that is ethnicity, she may not agree. And then my choice will be steroid. So it depends upon what her values are and have a good discussion with her. But I wouldn't jump to RAS inhibition, glucose transport inhibitor without discussing her what she wants to nurse or not nurse. That's very important here.
No, it is extremely important. But of course, I wrote this not even thinking about that, because my audience is always smarter than me. But that's why I want to kind of take it out of the equation. So I'm going to say that she comes to you and she says, I'd like to nurse, but I really want to do what's best for my kidney, Dr. Reen. What is that?
Yeah, then I will tell her that use a budesonide if she wants to do that, even a prednisone after discussing with her the side effects of the drugs. And so it's a difficult decision, but that's the way I will approach.
So you're not allowed to pick two. You're allowed to pick one. Would you?
Okay, let's see if she's nursing, then my choice will be steroids.
Okay. Systemic.
Yeah,
sorry to be.
No, it's okay. It's fun actually.
Yeah, that's what I really want to do. Dr. Glassick, what would you do?
I would go with prednisone and the supportive therapy initially because of hematuria.
Mm-hmm.
Persistent high-grade hematuria and this degree of progression with sclerosis in the areas where necrosis was present implies to me an active inflammatory process, and I would use steroids. In this case, oral systemic steroids in moderate doses, like in the moderate dose steroid regimen used by the testing trial.
Exactly, yeah.
Testing too.
I've always been very reluctant with steroids and IgA, but I'm so thankful for the modified steroid dose in in the testing trial because it makes me feel much better about it. I think that's would have been my choice, but anybody have any strong feelings about any of the others? Anybody have a strong feeling about hitting this hard with immunosuppression, Dr. Corbett?
No, I mean, I don't have a strong feeling one way or another. I just kind of enjoyed the conversation. In general, I would probably just have started with, an angiotensin receptor blocker, see how she does with that over a few months, and then decide whether they add the SGLT2 inhibitor. The part that makes me really nervous about this is that she is ANCA positive, and we're not, it's not just a fluorescence. She's got PR3 and MPO, and I still can't quite reconcile, whether that's a factor here or not, superimposed with the IgA nephropathy. Because if that were the case, then I think we'd be treating her like a vasculitis. And that's the part I wrestle with most is this an ANCA vasculitis that we're dealing with in someone who happens to have background IgA nephropathy? I mean, she clearly had active lesions. Granted, there were 2 out of 19, but Christ, if this was somebody that was just MPO positive and had 2 necrotizing lesions, we wouldn't even be discussing it. We would be giving immunosuppressive therapy plus the other things. That's what I kind of wrestle with. So I'm kind of curious as to how other people feel. I guess, you could give steroids, that would help treat that, but we know that patients that have ANCA vasculitis, even though they'll respond to steroids, are going to relapse more likely than not. So I have to admit, that's the part I'm wrestling with. I'm curious to see what other people feel, and pretty much everybody's kind of had a different approach.
So Steve, though you're wrestling with it, but you're not allowed to wrestle. You're only allowed to give me an answer. What would you do?
I would treat her with Racin. I would take number 4 minus the nursing part that we're going to take out of it. I know that throws a real wrench into everything. And then if you throw the nursing in, then I would do what Dick says. I'd give her steroids.
So what about? So let me ask. So number 4, you want to give her immunosuppression?
Yeah.
Now, didn't you just recently write a paper on crescentic IgA?
I did, but those people, we eliminated patients that had ANCAs.
Okay, so this is.
So if you want to talk about IgA with crescents without ANCAs, we can talk about that.
You made your point, and that's what I was kind of looking at. I was thinking. So you're putting the weight on the ANCA.
Yeah.
Okay.
I can't explain why she would be positive for all 3 unless she's snorting something we don't know about, but I kind of doubt that.
Yeah. Okay, I'm going to hand it back to Bill, so he has plenty of time. I know he's got some thoughts about this. Bill?
I have a question for Dr. Corbett. How common is renal limited ANCA vasculitis?
Well, let's put it this way. You look through the literature and at least finding crescents or even segmental necrotizing lesions can be seen up to 50-60% of the patients, but we're not talking about greater than 50% of the glomeruli with crescents. We're talking about just 1 crescent or more. So it's actually more common than you think. In our population, it was about a third.
I think he's also asking about extrarenal being so quiescent.
Oh, I'm sorry.
Limited.
But then you get into the area of henoch purpura, and again, we eliminated those people from our study in particular. So if you take HSP out of the equation, which is more of a systemic vasculitis, then we're talking about people who basically have renal limited.
Okay, so we've got arguments for all of the above. We have arguments for RAS and alone. We've got arguments for steroids. We've got arguments for immunosuppression. Bill, why don't you take it over from here?
I'm glad there was sort of a struggle because I was really wrestling with this too. Despite having this in 16 weeks of pregnancy, she really was doing pretty well, essentially 6 months later. The data on ACE inhibitors is that it does cross into the blood, into the breastfeeding milk, but it doesn't usually, if you wait until after 4 weeks, you are out of the angioedema scary category. And so it may get into the breast milk, but it's not supposed to have any fetal harm. And so ACE inhibitors were fine. I don't have enough data for breast milk and SGLT2, but I would never start them both at once. Anyway, I would make sure that somebody was on one once first, see how they do, then you can see the effect of it. And then I would add on an SGLT2 after that. So Pravir, can you
Oh yeah, do you want me to, do you want to click on the screen? You can.
sure.
Yeah, there, yep, you're
There we go.
advancing
Thank
the
you.
slides, yep.
So, first we had talked about renal biopsy in pregnancy, and I did this biopsy myself on this patient, but that was postpartum. I have done a couple, but the case series are pretty limited, but the complication rate is essentially the same as it is in native kidneys. It's obviously a bigger deal though, and I think that there's ethical issues. There's the concern that there's maternal fetal harm with that complication, so it's a little bit bigger of a deal. And so in general, if we can try to treat through pregnancy with whatever we can treat with, then we try to avoid it. But there are times where we really do need to do a biopsy. And if it does get later, yes, we were talking about different positioning of there's the left lateral decubitus position, and there's sort of a sitting up position, and all of those have been reported on. But in general, in the prone approach, the complication rate is close to 2%, similar to that in native kidneys. So what I did was I actually just started lisinopril 10 milligrams a day, and she's still now, I have data on her. I don't have the exact dates. We had changed those a little bit, but we have data up to about 4 to 5 months after the biopsy, and her urine PC has improved to 1.4 grams per gram. She still has hematuria, to Dick's point, which is a little concerning. And her serum creatinine is rock stable at 0.7, which is what it was 1 month postpartum. All of her serology now, though, is completely negative. So, but I really wrestled with this on what to do. I mean, if those segmental necrotizing lesions were due to ANCA, or even if they were due to, we see those in lupus, I wasn't treating those. And that was a real conundrum for me. And I was really worried. And so I actually got several follow-up labs during this time. And luckily, or fortunately, she did quite well.
No SGLT2 inhibitor, I take it.
No, I would never start them both at once. I don't think that they've been studied that way. Actually, I know they haven't been studied that way. I would start one, and SGLT2s have never been studied unless they've been added on to ARB. Now, if she had a contraindication to an ACE, I would start an SGLT2 right away. But I want to see where she kind of naters out with lisinopril first, and then I eventually will start a flozin. But the real conundrum I thought in this case was this, which was, it was really tough to figure out, positive ANCA, IgA nephropathy. And so what's the data? And there's not that many patients that have reported but almost all of them have been treated with immunosuppression, but almost all of them had presented with either acute renal failure, alveolar hemorrhage, some sort of systemic sign that pointed towards ANCA being more positive. And so this study had analyzed the features of IgA nephropathy alone compared to IgA nephropathy or IgA with crescents compared to vasculitis itself without IgA, which was ANCA positive. And they found that I went too fast. And they only had 20 patients with ANCA positive IgA nephropathy, but they compared them to regular IgA nephropathy and then vasculitis. And they found out that the presenting the ANCA was also could be a PR or MPO or PR3 in those cases. And so our case wasn't that unusual. And I think one of their cases out of the 20 had dual positivity. These were their presenting things. 45% of them had crescents. Their average proteinuria, again, in the ANCA IgA patients was 2.4 grams on presentation. They almost all had an increased serum creatinine, similar to those with vasculitis. And so this is sort of a different population than the patient I have, who has normal renal function. She did have a similar proteinuria, but she had normal renal function. And so almost every single one of these patients was treated, though, with either corticosteroids, 75%, pulsing, cyclophosphamide, and some of them presented very, very late. And what they found, though, is that the prognosis was very similar with the prognosis was worse with IgA nephropathy compared to treated ANCA vasculitis over here or treated ANCA IgA nephropathy. So they're suggesting that you should treat, but they did not have many patients, like I said, that didn't have such mild clinical features. And so I'm sort of making a case for our patient's mild clinical features is what defined whether I was going to treat or not. And so far, she's doing quite well. Now, will that change? Will I be giving her something in the future, low dose steroids, similar to target 2, it's possible. I'm definitely going to be following her closely though, and make sure that she doesn't tip over the edge. So far though, she's had quite a nice response.
Go back on your, go back in the previous slide. I'm just curious about something. Yeah. So a lot of these studies combine fibrocellular as well as cellular crescents, and then they eliminate the fibrous crescents because they're not considered active. So on average, they had 25. So they were all around 25% if you add the two together, which is interesting. So in this whole, we've talked about this before, the whole issue of what proportion of glomeruli with crescents does that define? Is there a break point at which you would treat them? And as we've talked about before, KDIGO basically gets away from that and says, no, we don't use the percentage of crescents, we use their clinical course, which I find interesting because I think most of us get kind of nervous with that. Mark Haas showed very nicely in his paper, which is what kind of the new classification of the Oxford classification got redefined with, including crescents. And they found, if they had less than 25% crescents, those patients that got treated essentially did just as well as the ones that had no crescents, relative to the ones that had 25% or less and didn't get treated. So if you had less than 25% crescents and you got treated, you had basically the same course as if you didn't. If you had more than 25% crescents, the ones that got treated didn't do as well as ones without, but they still did better than if they weren't treated. So it seems like treatment does have some benefit. And I think for all of us, or at least for me, it's kind of hard when you see this to not treat. It's just the question of at what break point would you use to treat them? And again, with ANCA, for me, it kind of created, kind of makes it a little different, but apparently in this paper, it doesn't really seem to add that much.
Well, in KDIGO, like is being discussed in the chat, that was also published prior to what was it called, Target 2, or the newer low dose steroid improvement testing 2 trial. And don't forget that not only was that low dose steroids, but they also used pneumocystis prophylaxis. So that's an important part that wasn't done in testing 1. Not only higher dose steroids, but they didn't use that. But I think it's possible that KDIGO has a little bit of a different stance, knowing that steroids has helped patients with IgA nephropathy now in such a positive way in the testing 2 trial. And their update, which is probably going to be about a year from now, we'll see if they really are just using their clinical course or whether they would change that a little bit in the situation where there is crescents.
But it's interesting, and remind me if I'm wrong, because I haven't looked at it in a while, and you've probably looked at it. In the original testing, they basically talked about the percentage of patients that had crescents. In the second paper that they came out with, they don't even mention crescents.
That may be, I'm not sure.
Dr. Whittier, if her proteinuria is, let's say 900 milligram with the lisinopril, it goes down, but still has blood in the urine, you will continue the course or you will change the gear then?
Yeah, that's exactly my concern. So thank you for bringing that up. And I said, yeah, and that's what I said when I showed this slide, is that the great proteinuria came down, but there's still blood there, less red blood cells, but are we really going to rely on that? No. So yeah, I mean, it's possible if I get out a little bit further, and, also depending on what her proteinuria does, but I don't know. I mean, her ANA and ANCA are now negative. Her proteinuria is coming down nicely. I know that hematuria can last for some time. I don't like that that's still positive. If it's still positive in a year, would I consider some sort of immunosuppression? Maybe. Yeah. So I kind of am going to follow her very closely. Like I said, she's certainly not in complete remission, but she's just doing better than she was.
Yeah, complete remission in IgA is a slippery slope anyway, but what you're really shooting for, of course, would be getting that proteinuria down well under a gram, and hopefully some of the hematuria as well.
And I don't think any of the answers on the poll of treatment were wrong. I mean, I wrestled with them and did this one, but I don't think any of them were wrong. Except the sparsentan plus the
Thanks.
Yeah.
Appreciate that, Bill.
Yeah, sure.
Here I am. Here I always tell you I have your back, and you throw me in the bus.
Just a little dig.
At 2 hours and 7 minutes. I think we'll wrap it up here, unless anybody has any other questions or comments. I do want to say something before everybody takes off. Dr. Reen has a very nice biopsy conference he does about every month or so up in Toronto. He's going to have one next Wednesday, 6 p.m. Eastern time, 5 p.m. Central time, 4 p.m. California time. If you're not on his mailing list, he's going to put his email address in the chat right now. You can email him and he will add you to the email list for that. So Dr. Reen, if you can throw that in there, people can copy it and we'll just keep it open for a minute before you sign off. It's a really nice conference, and he always has a couple nice cases with discussion and good pathology. And so that'll be next Wednesday. We do have another conference also the day after Thursday. We have a special guest, secret guest as well, which will make it fun. So is it in there yet? Do I see your email? There it is. Okay. Beajar, I'm not even trying to say that, but it's right there. So copy that address, send him an email. He'll put you on the emailing list, and I think he'll put you on it for good. He, like all of us, wants as many people to come to these as possible. Great discussion, nice case, difficult case. It's unusual that the outcome is different than the poll, but that's of course why we do biopsies. I want to thank everybody for coming. If you're not on our mailing list, let us throw us an email. We'll put you on there and join our YouTube channel. These will be up shortly. And until I guess next Wednesday and Thursday, everybody stay safe.